Now we have a really incredible person who's going to be presenting our advanced prostate cancer talk today. Her name is Dr. Elisabeth Heath. She is the Associate Director of Translational Sciences and runs a multidisciplinary genitourinary oncology team at Karmanos Cancer Institute, and she's the Professor of Oncology at Wayne State Institute. She has a ton of background in doing amazing research when it comes to advanced prostate cancer. And she's a phenomenal person, but one of the things I love about Dr. Heath is that she is so good at explaining really complex, intricate systems when it comes to treating advanced prostate cancer. So back in 2023, she did speak for us, and we really appreciated her talk because she broke it down into different treatment boxes and kind of helped us contextualize. But there's even been some new treatments that have come out within the past year. And so within her talk today, she's going to talk about those new treatments and help us again contextualize where you fit when it comes to advanced prostate cancer and what treatments work for you. So without further ado, we welcome to the virtual conference, Dr. Elisabeth Heath.
Thank you so much for, number one, coming out. I know that this is an effort, really, for all of you to learn. There's so many different ways to learn now that doing it in person, I think, is so much more meaningful because we can connect on a whole different level. My personal thanks to PCRI, that dream team of 3 wonderful people right there making it happen. And also, just on my end, knowing what this organization does for my patients in Detroit, I'm just overwhelmed to be here and to also be back up here, because the last time I was here was a year ago. And I said, you know, if you have me come back, I might have more treatment options on a particular slide that I'll point out to. And the answer is there are more treatment options. So my job today is to kind of get with all of you to maybe do a quick landscape, big overview of what are the new treatments that are out there in advanced prostate cancer. And then you have the entire meeting to really dissect out all of those different types of treatments. And why that's important is because you then become empowered with the knowledge yourself so that you can ask. Sometimes the thing about prostate cancer or in any cancer is you don't know what you don't know. And then when you find out about it because your neighbor told you or your family member emails you and you say, why didn't anybody tell me that? Does my team not know? Do they not know? Do they not know? Or are they holding it back because of a particular reason? Is there something special in the back room that I should know about that I didn't know about? And then you start to lose a little trust and a little faith. And that's the part where you guys yourselves, your family members, your caregivers can make a difference. Because if you know it yourself, then you can be your own best advocate. So we're all in this room advocates for this disease, and in particular, advocates for learning, because what I said a year ago has so many more updates this year than last year. We're barely keeping up in the medical profession. So conferences like this is important to me too, because then I get to learn as to what you are all thinking. So the good news is, although I only have a little bit under an hour, there's a lot of material. And if I was up here 15 years ago, there wouldn't be that much to talk about. I'd be done in 20 minutes. So that's the good news. But the bad news is it's a lot of material. So my slides and everything else will be available so that if you have questions and whatnot, please feel free to ask, especially in the next session. So it's a pretty global title. And you guys know me from last year where I've been in Detroit, Michigan for the last 21 years. I'm an active clinician. I do a lot of clinical studies and drug development. But these numbers are a bit more troubling as time has gone on. And what I'm worried about with these numbers is that they look higher than they were 10 years ago. And you're like, how can the incidence actually be going up? Well, you could say, well, gosh, you know, many moons ago we stopped checking PSA. So now we're checking it again, having more shared decision-making moments. Maybe that's the case, but the number of deaths is still kind of high. So the big disconnect is I have a lot of new treatments to share with you. But why is that not translating into lower annual deaths from prostate cancer. And that we still don't have an answer. So what does that mean? None of us are free to go home to say the problem is fixed, that it's licked, and we're done. Everyone still has to show up, whether you're contributing to a trial, whether you're just informing everybody else, to try to handle this. The good news, though, is that majority of patients still present with localized cured disease. So if we get the word out for risk, and that's a whole other thing of screening, which I think you guys will talk about, it will be really important to catch folks early, because if you catch it early, you have a higher chance of better cure, long-term remission, and overall survival. We also know that the metastatic cancer is much more different than it was even 10 years ago. We know the biology a little more, we know the genetics a little more, and that's translating to some new advancements in clinical studies. These are also sort of staggering numbers. So I just came back from 3 days in Washington, D.C., where I'm part of the steering committee for the American Cancer Society. They just launched a national prostate cancer roundtable so that the American Cancer Society is now even more committed to getting prostate cancer addressed. You know, we'd like to cure it, of course, but at least throwing more resources so organizations like ACS and Zero and PCRI can, you know, help further that. But look at these numbers. You know, for men, prostate cancer alone will account for 29% of that cancer diagnosis this year. That's a huge number. Look at that incidence rate, and since we're talking about advanced disease, that rate has increased 5% per year for advanced stage cancer. Okay, as a medical oncologist, I don't want to see that. You folks as patients with loved ones, caregivers, you don't want to see that. And when you're looking at this in a higher risk patient group in Black men, that incidence rate is 68% higher than in white men. 68%, twofold higher mortality. So we are nowhere close to being done. It's going to take the entire room here as time goes on to make sure that we can all work together to try to solve this problem. And it's so many different facets. Education is one, trials is another, newer drugs, better understanding, earlier detection, you name it. It's whatever you pick as your cause. By showing up here today, you've already contributed to the mission. Because this clinical states model, as you guys can see here on both the left and the right, that hasn't changed. And as physicians, we still think about cancer this way. So when people sometimes in your, you know, we like to use a lot of doctor speak when we see you folks, and you're like, well, you're in that castrate-resistant space, or you're in the biochemical relapse. These are just terminologies we kind of turn around, but you guys now know that this is the algorithm we pick, so there's no mystery. I'm here to demystify stuff today. This is important stuff because sometimes you got to ask your doctor, where am I in this thing? Am I at the left side? Am I at the right side? Am I the blue box? Am I the green box? Where am I? Because when you sometimes even read your own notes in your medical records, you're not really sure where you are. People will just say you have metastatic prostate cancer, you have advanced prostate cancer, you have biochemically recurrent prostate cancer, you have high-risk prostate cancer. What does that mean? So, number one, we don't expect you to know this. We just want you to ask your physician, where are you in this? I don't know. Where am I? So we're going to talk a lot about what's happening in the green boxes after you've been on hormones and the cancer's not behaving. But you know what's kind of messing things up a little bit? Is not knowing this makes this more complicated. So if you look at the risk group, and I think there are breakouts, which I think is just brilliant today, where you can say, okay, I'm going to talk about my options if I'm very low risk, low, intermediate, high, very high. And what you see is completely different recommendations, but in the very high risk, I put these guidelines that we use in our practice known as the NCCN guidelines. And look at where it says abiraterone. And for those of you who are in the advanced space know that that's a novel hormone therapy. For those of you who are like early and saying, well, wait a minute, I don't even know what that means. I can't believe I'm having a discussion with you about a systemic drug in this early localized space, blue box. So if this is showing up right in the beginning on the left side of your clinical state, what happens when you're green? And those are the kinds of questions that's making us in the medical world think really hard about how to think about the strategy of the treatment options. Because if you're exposed to this because you have very high-risk prostate cancer that's going to get treated with radiation and hormones, what happens in the future? Is there something that I need to know? How long do I do this for? So the pearl from here is to recognize advanced stage disease is a term of where you are, but the treatments for it are not necessarily confined to just that spot. So that's where it gets a little tricky. So you guys are now all in the know. You all know that these pills and novel agents are coming earlier and earlier. So you don't have to be an advanced patient. You may be able to have access to these medicines right up front. So an important piece of knowledge. But here's the list of all FDA-approved drugs. And when I was here last spring, what was noted was the last two red boxes on the right were not on the list. That's because a few months after we were done speaking in March, they became FDA approved. So right after we just met, top of the line, new stuff, two more boxes popped up in 23. And that's the kind of information that's critical for events like this and why PCRI is such a leader in what they do, because if you don't attend this, you might be looking at my stuff from a year or two ago. You won't be the updated. You want, as a community, to show more boxes because it shows progress. So we've got things in yellow, which are all chemotherapies. We have that box in purple, which is an immunotherapy. And it's the only one that's approved in prostate cancer. We have the green boxes, which are all androgen receptor modulators. We also call them novel hormone therapies. Sometimes people call them ARPs. However the language is, it tackles that androgen receptor. We still have Radium-223, and that is a medication that Marie Curie discovered a bazillion years ago. We have relugolix, which is an oral androgen deprivation therapy pill. We now have lutetium-177 PSMA, which is usually the talk of many of these discussions for a newer class of drugs known as theranostics. And then you have the 4 red boxes, which are known as PARP inhibitors. And they tackle the cancer in a different way, but also all pills. So that's the comprehensive list for therapeutic drugs that are available today, that if they don't seem familiar to you and you're an advanced patient in the classical sense, you can take this slide and say, what about that for me? May not be applicable. They may say, listen, this is not appropriate because of. But you then will be empowered to know, hey, this option still exists for me. Okay, so where we are in research is still, we can't get away from the androgen receptor. In a way, in breast cancer, it's a little similar. It's all about the estrogen receptor. So in prostate cancer, it's all about the androgen receptor. And here's a really complicated slide, and all it tells us is that when that pathway goes wonky, is what I like to call it, that cancer is so smart, it has so many different ways to try to fix itself. It finds a way to survive. Cancer sometimes is a bit like cockroaches. You think you killed them all, there's always one left. You're like, I thought I got that one. No, no. And when you see one, there's probably a zillion more. And why that's important is because when your doc sometimes will tell you, we need to combine things because these two things got smart and they are trying to break through by 2 ways. Sometimes we put 3 things. Sometimes it's completely different drugs. Sometimes it's the same type of drugs. So this is the linchpin of every trial that's still in existence right now. But there are so many other neighbors around there that if you look at it from a drug development standpoint, there's lots of many ways that these prostate cells get really smart. And that's where you see a lot of these different drugs that are no name, just letters and numbers, getting tested because somewhere there's a laboratory that shows that these prostate cells are dying in the laboratory. It's a start. In general, whether it's the injections or the pills, I put this here to just show that it affects the entire man. When we take away your androgen or your testosterone, everything in a way is impacted. There's not one is worse than the other. I look at it as the whole person. So in one man, hot flashes might be really terrible because he's sweating when he's in his office job talking to his boss. And another might be tremendous weight gain that then precludes this person from doing an active physical job. Whatever it is, it's all 100% geared to what is the most important to the patient. So I see a lot of studies, it's like, well, these are the top 3 things that are really terrible. These are the top 10 things. You know what? I think it's all terrible. Men are supposed to have testosterone, like women are supposed to have estrogen. We're supposed to function with it. That's how we're built. So when I physically take that from you, there's damage to be done. And I don't think you should minimize it. I don't think you should just say it's a big nothing burger. It's huge. Now, how you choose to deal with it, my best suggestion is communicate to your physician and team, because we don't know how to prioritize this list. Is it hot flashes? Are you really worried about diabetes? I had a patient that was the most worried about a stroke. And I kept saying, you know, stroke's on the list, but it's quite low. Why are you worried about that? My whole family's had strokes. They hit 70, granddad had a stroke, dad had a stroke, my uncle had a stroke. So listen to what is the most troubling, because it might be something that's very specific to that patient and or the family. Still holistic care. But anything that we do, whether it's again injections or pills, we're making some slight adjustments, a little better here, a little better here, but in general, it affects all of the working parts of a man. So my advice to all of you is, don't be shy, guys. Even if your doctor's a woman, we get it. Say what it is that's troubling you, because it's not the same for all of you. It's not the same at all. So that's, I think, take-home point as well. And what's happened is we were talking about how you get from, you know, one drug to 2 drugs. If you are newly diagnosed and you show up, let's say, to your doctor's office and he or she tells you, you now have spread cancer to the bones, let's say. The message of today is, one drug is not enough. All right, we're all gonna say it together. One drug is not enough. Why is that important? Because adding a second medication improves your survival to an incredible amount. Just look at those boxes on the right. Decreasing the risk of death by 34 to 40% versus an injection or a pill alone. And you're like, how can we not be enamored with this? Well, the thing is, all of those things I list that I don't expect you guys to know, it just shows that one drug is not enough. But in reality, we're not prescribing this. Half of you are not getting this as standard of care. Half. I'm sitting here going, hey, listen, a lot of trials, a lot of boxes, blah, blah, blah. Guess what? 2 drugs better than 1. Great. If you don't get it as part of your treatment plan, have I helped you? No. So the message of this really busy slide is, if you're newly diagnosed and your doctor tells you, we got to get rid of your testosterone, but you now have bone metastasis or lymph node metastasis or liver or lung metastasis, the answer is, great, am I getting 2 drugs or am I getting 3 drugs? That is a piece of knowledge that we are not implementing. I'm educating all over the place, but I can't get the message through. And I'll show you data to show that. But if you say, well, what is happening in the office? You know, when you see me, what are we doing? Are we eating bonbons? Am I running from room to room? No, you're thinking about why would I say 1, 2, or 3 medications? These are some of the factors that affect us in our daily practice. Sometimes it's as simple as this is how the office runs because the person in the front knows to call the pharmacy person who she has a link with that person who has a specialty link to somebody else, and that's a process. Just think about this. If you guys go shopping at a particular supermarket, you probably do that all the time. Once in a while, you might change where you go, but it's a process. It's easy. You know where the stuff is. The cereal is on aisle 8, your fruits are on aisle 1. You don't have to think too hard. In clinical practice, the same thing happens. If it's easy and we've done it, it's usually what we do. The other things we take into account is what else is happening with the person? Are you a high risk for stroke? Do you have uncontrolled diabetes? Do you have uncontrolled hypertension? Because guess what? Cancer doesn't care what you came in with. It's going to muck up everything. So I've got athletes who are world-class runners. They got prostate cancer. I've got the worst couch potato, a self-admitted couch potato that literally has a shirt that says, I am a couch potato, and wears it proudly to the office. And guess what? He doesn't do much, but everyone comes in with different things, so you have to tailor. What's great about medicine is there are options. So sometimes if you're like, well, you know, I was talking to my neighbor and, you know, he's on this pill and I'm on this pill. Why is that? Well, you're not in that person's shoes. The question that you can ask your physician would be, hey, guess what? My neighbor's on this thing. Was that ever something consideration for me? And have a discussion. The other part is sometimes there's no coverage for a lot of these medications. California is lucky because it's got the oral chemo law, but a lot of other states do not. Now, Michigan finally got our bill passed, House Bill 4071, and they now have an opportunity to be able to get the pills covered like the chemo. And that won't be until 2025, but it can happen. So there are a lot of other nuances. And the take-home message for that is ask your team, why this, not that? If you look at this clinical considerations also as to why we pick what we pick, nothing on this slide says why, from a patient standpoint, should I pick it based on how you feel. This is just what you look like on scans. So what isn't in our research is, how are you feeling? Are you losing a lot of weight? Are we having a lot of bone fractures? What's happening to you? They don't show up on our studies. You need to make yourself relevant to the conversation. You say, excuse me, I'm a marathon runner. I kind of have these concerns. Speak up, really important. As one presents an advanced disease, not everybody's the same. So if you show up with a lot of cancer for the very first time, never having had it, you have a very aggressive cancer. We know this just based on those research points right there. If you come in with one lymph node and your cancer was 15 years ago and it got treated with radiation, your survival is different than the first patient I mentioned. Now, is that important for you to know? Yeah, you know why? Because if you're in that first pot, you say, listen, I know my cancer is going to be aggressive. What's the plan, doc? Advocate for yourself there. And all these pills that we talked about, they're in long-term follow-up now. So the good news, and the second question is, all those boxes were made many moons ago. What's happened since then? Is the data holding? And the answer is the data's holding. These pills continue to provide an overall survival advantage. So what you want to know is, here's the great news flash from many moons ago, it's just that the standard of care is holding. And there are things, and my number one question I get from my patients, great, we're gonna start 2 drugs. How do you know it's working? Is it the scans? Well, doctor, you never tell me that my bone scan probably won't change much. How do you know? PSA. So if your PSA doesn't bottom out to 0.2 at 7 months, that's a worry. So that's something we can use together to monitor. 0.2 at 7 months, okay? Really, really important. When I say half of you is not getting the medications, these are the types of studies they call real-world data. They look at big, big, big data sets that Medicare, Flatiron, lots of data repositories look to see, oh, blah, 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 Heath's up here doing her level 1 evidence talk, great professor. How are we actually executing this? And the answer is not well. So you guys now in the audience are part of the solution. Because if we don't turn this around, half of us in this room is not getting life-prolonging treatment. And that is not acceptable. Is it just us? No, it's happening throughout the world. So this is not a US-based problem. If you look at what's happening in France and Germany and Italy, if you look at the green boxes, it should be 20%, 10%, 0, because the green just means 1 drug. How much green is in there? This is stuff we already knew from years ago. So globally, we're failing as a community too. So that's really important, because if you're looking at chemo as part of this story, because chemo is part of the triplet, so you can get a shot, a chemo, and a pill, whether it's the one yellow box or the other yellow box on the first, these are general side effects. But I have the same comment for this as I do for the androgen deprivation. It affects your whole body, folks. So it's not that it's not manageable, but you need to recognize chemotherapy is serious. We don't offer it just because. But if it extends your survival by a huge amount, you got to really think hard about whether this is something you want. Talk about it. Generalized side effects. They're temporary as you're on the treatment versus when you're off the treatment. What do we look at? Do I look at you and go, I don't know, you don't look so good. I don't think I'm going to give you chemo. No, we actually use other parameters. Here's a table that we use, because sometimes you say, well, why can't I get chemo? And I point to things like number of falls in the last 6 months. When was the last time your doc said, have you fallen recently? It's not a question that comes up in normal conversation, like, hey, have you fallen recently? No, first of all, you're embarrassed, so you don't really want to talk about it. But when you ask, you go, well, yeah, last month I sort of tripped on my way to the mailbox. Oh, I was walking my dog and my dog pulled this way and I kind of fell. But a risk factor is number of falls in the last 6 months, 1 or more. So you fell in the last 6 months. You're at higher risk to not do so great with chemo. And the right side just tells me the higher number of points you get, the worse you're going to have as an outcome for chemotherapy in terms of that side effect list. So you yourself can empower yourself and go, okay, I can't really walk 1 block. I sort of fell 3 times. I'm kind of anemic. Oh man, I better bring these things up to my docs. Really important. The chemotherapy is in right when you're newly diagnosed. It's also in those green boxes we showed earlier in the castrate-resistant space. It's not going anywhere. Chemotherapy is highly effective. It helps with survival, but none of the drugs I'm talking about cures. We know that. But if I can keep kicking down the end, which is death, further and further away from us, I think that's a win. It's just a matter of a balance. Here's an update. The second question I get a lot is, what if we just combine the chemo and the pills like we do in the beginning, as I just mentioned with the triplet, when you're castrate resistant? Why don't we just do the whole thing at once? So here's a study ran by a cooperative group, and here's the final assessment. Didn't really do much. So this really important take home here is, even though I say in the beginning, you need at least a doublet or a triplet, it's not necessarily so if you're castrate resistant. So now we have to be even more thoughtful about the data, because if you just sort of combine things, you get more side effects, no additional bang for your buck. And that's not what you want. So do we know this for a fact? We do, because that clinical trial took forever to finish. So I come back to this list again, and we say, okay, so chemo we talked about, I'm gonna talk about the other bits, but you know, there's something on this list, especially in red, that I better pay attention to, because I don't know if I'm a candidate if I don't test. And I believe there was an earlier lecture that kind of looked at that, where testing is the other parts we are bombing out, you guys. I mean a fail. I would grade our community as a big F. It's not even a D minus, it's a pure F. Why? Because we're missing so much of, all of you actually, to know who should get tested. So, who understands that genetic testing now is standard of care in prostate cancer? Okay, my hope is that after today, the entire room raises their hand, because you are missing an opportunity to get one of those red pills if you're an advanced patient, because your doctor doesn't know. And advanced testing is not what you get on your prostate biopsy. So people often ask me, well, I was, after my biopsy, I had these tests sent. They're all a form of testing, but it's a different form of testing compared to what you see here. This is a little cumbersome, but the message here is that there are high-risk features that you come with that you may not know of, or no one's asked you, that basically you should get testing. And testing, for sure, there are many types, but I'm calling inherited germline testing as the standard. So that means your mom, your dad made you, gave you your DNA. What is happening in that original blueprint? So very, very important. If you have metastatic cancer, it is a given. It is now standard, you should know. So many of you are not getting tested. I just know that because we have data. Why is this important? Because if you are not tested, you don't know if you're a candidate for those 4 red boxes. Because those 4 red boxes are only approved in people who have a certain genetic abnormality. See the problem? You can't get the drug if you don't know what you have, but you don't know what you have if you don't test for it. And you don't test for it if no one actually does it. The DNA damage repair has been a world of research for a gazillion years. It just shows you the DNA is pretty fragile. There's a lot of ways to bust it up, and your cells are really smart, and it wants to fix it. So this pathway with the red cells, with the red boxes, is to really capitalize on people's DNA repair pathway. Just doesn't work a certain way. You're there to try to capitalize on that weakness. Is that important? Yeah, those are the 4 red boxes. If you look at that, they're very specific in its approval, but they all say you have to have a particular mutation. So HRR mutation, who knows what that is? Anyone? Right. So I always tell the FDA, that's really great, thanks for a bunch of that, but it's not helpful for the regular community. But there are many of us in practice, because there are so many new findings in cancer, that don't know even to check for this or what the results mean. So sometimes, and many times, I get a call of like, I need somebody to decipher what the test says. I got a result, I don't know what it means. And frankly, they're a bit embarrassed. I'd be embarrassed too, because there's a bunch of tests I can't read if it's not my area of expertise. But everyone here is probably familiar with the breast cancer gene. So these are all the nasty breast cancer gene and its most wanted family members that qualify into that pot. They're different for each of these pills. So they're not exactly the same. But who's heard about at least the BRCA1 and BRCA2? Right. And we know that because the breast cancer world is so good at getting that knowledge out. You've got the Angelina Jolie effect. You've got a bunch of famous people that will push that forward. In prostate cancer, not much. But you can't get any of those pills if you don't check. What are some of those side effects? They're a little bit different than the hormones. So here we really worry about anemia, like a lot. So you're gonna say, well, what can I do about that? Well, if you're already coming in anemic, you might have a more iron-rich food. You might want to pay attention to if there's any blood loss that you have, such as bleeding from your stool and things like that that's happening. Maybe you're already on a blood thinner. Knowing what the side effects are is really important, because if you're a person, for example, that's chronically anemic, those red box pills may not be helpful to you, may be harmful. There is a category of side effects called myelodysplastic syndrome, and that just means your entire bone marrow conks out. So we talk a lot about that. It's very, very rare, like maybe 1 or 2 patients per study. But it's not 0. So is that important for you to know? Sure, because you want to have a discussion about that with your docs. But how are we doing with testing? Look at that last bullet. 62% of men in the advanced setting did not receive any genetic testing. 62% of men didn't know if they were eligible to get those medicines in the red boxes. This is another big study. They just looked at what got ordered. It's pretty easy, right? It's not a bunch of curves, it's not a bunch of data, no stats. It's just how many of people got what. We're missing 62% of you. That's scary to me. So we can do better. This conference, all of you are going to be empowered to make sure that we do better. The number one question I get in terms of genetic testing is, I don't want my insurance, or I don't know if it will cover it, I don't have enough money to pay for it. This is a free registry. Everyone write this down, prostatecancerpromise.org. If you have any stage prostate cancer, any stage, you have a PSA of over 100, even without a diagnosis of prostate cancer, or your bone scan or some scans is suggestive, you're in. You just go onto that website, you answer some questions, you will then get a kit, you swab your cheek, you'll get your information for free, okay? So I'm not gonna advocate that we do something and not give you a way to check it yourself if finances is an issue. Really important. The other things that genetic testing takes is, as I mentioned, we had Sipuleucel-T is the only immunotherapy. The only other immunotherapy is pembrolizumab, or a medicine called Keytruda, and it's only approved in people who have a specific abnormality when you do testing. And in 3% of men, 3% is not 0. And I say this because I have those 3% in my clinic. This medication works, not cures, but is working in men who have what we call microsatellite instability-high tumors. Fancy language, same problem. You don't check, you don't know. Guess what? If you're that 3%, you want to know, right? Why would you not have that in the box of things to go and help with your docs? There are a lot of studies going on. I have to say the worry for us in immunotherapy is that it really doesn't work, not well. So these are just bunches of examples that can, sort of show us that the trials are run, just like in lung cancer and breast cancer and colon cancer. But in prostate cancer, it's not been as exciting, and or the return on that investment has not been forthcoming. So different biology. We're still working it out. But there is one drug that is approved called Sipuleucel-T. Now these are folks, you're just turning castrate-resistant. You've been on the injections for a while. You have a few cancer metastases. You otherwise feel fine. You're a candidate, there's an overall survival benefit, it's been approved since 2010. So for the right person, this is still a very active treatment that can prolong survival. And we also know that, again, we talked about how Black men have the worst incidence, worst mortality. Here, the overall survival with Sipuleucel-T in Black men is actually better than in white men. So a different way to think about data in higher risk groups. And who are those higher risk groups? We talked about Black men, but those with a family history or genetic predisposition, same group. You're high risk. So I know that will probably come up when you're talking about the screening after surveillance groups later on today, but really important to know where you stand, especially genetically. And some of these side effects are what you would imagine for immune-based treatment. So this is also true for pembrolizumab. You might get infusion reactions, hypersensitivity, chills, fever, all very transient, all very manageable. Overall, still in active practice. I know a lot of urology offices that are giving this still all the time. So it's still an active medication that you can ask about. For the right person, for the right situation, it makes sense. The other medicine we were talking about is radium. So let me just show of hands. Who's familiar with radium?
Is that Pluvicto?
No. And I get that question all the time too. We're going to talk about that Pluvicto or PSMA, lutetium in a minute. But this is the original sort of, a lot of my patients call that liquid radiation, but this is an alpha emitter. So there's a bazillion ways to deliver radiation. And the radiation oncologists are in their heyday right now with the theranostics and all of the newer techniques for local treatment. But this is in men only with bone-only cancer. So if you have liver or a lot of lymph nodes or lung, this is not the appropriate treatment. This is still an active, life-prolonging medication. Now, some of the side effects that we worry about, as you can start to see, low blood counts tend to show up in every one of my slides, whether it's chemo or the PARP inhibitors or chemo, whatever. It is a side effect of everything we do because this is what happens to all of us. So this study shows that radium is for sure helpful, and then there's long-term data. So again, it was approved in many years ago. Where are we now? What are we most worried about? Well, what if you have low blood counts? What does that mean? Long-term follow-up shows that we are actually doing okay, that not everybody is getting what they call myelodysplastic syndrome or aplastic anemia, so it's safe. And I think that's an important message. How are we doing? We're doing okay, but with the addition of the newer theranostics, which we're going to get to in a minute, I think the medication use is going down, but it's also still appropriate for some of you, especially if you don't light up on a PSMA scan. So these are some of the studies there. So let's get to PSMA. Who's heard of it? Raise your hand. Right. So not only has it been a long time coming for many of us in the field, but it's good for two things, right? You can diagnose and then you can treat. So the PSMA, that's the transmembrane protein, you now have 3 types of imaging agents. So this is important because your doc may pick one over the other, and it's a fair question to ask your physician, why did you get me the one in the, why am I using gallium-68 versus F-18? I think most centers will tell you it's process-driven. It's whatever they have a contract with, and this is what they're comfortable with. But be mindful of the bullet points, because that's why sometimes you don't get the test approved. So if you are maybe not having a suspected recurrence, or the language isn't right on the note that the insurance company reads, then you're denied. So go back, rewrite it, do an appeal. This is important because without a positive result on the PET scan, you were not a candidate for the pivotal study. And this is, as the gentleman mentioned, Pluvicto. We call it lutetium-177 PSMA. And lutetium-177 is one type of isotope. There are many, that's the good news, in the making. Has this changed the landscape that if you're castrate-resistant and you've got chemo and you've had a pill that you can get on this? Yes. I have to say, singularly, this has made a big difference, but you have to light up on the scan. So if you don't show up anything on that PET scan, and as we say, you don't glow, or you don't glow enough, this drug may not work for you. So is that important? You bet, because this drug does have an overall survival advantage. You're still not cured. Some of the side effects can be bothersome. Again, temporary. I would say the top three: fatigue and dry mouth and nausea. That dry mouth is because we have a lot of PSMA expression in our parotid glands for some reason, and you end up being like that half the time, but it passes. So is this important? Yes. How are we doing now after some time has passed from that vision trial? Everybody's doing okay. Their quality of life is not worse. There's no additional side effects, because what's the other question? Do I need all 6, doctor? Some people feel that maybe dose 5 and 6 is not safe. Long-term studies showing that it is. So as we gather more knowledge, the big question now is, why can't we get it before chemotherapy? Why do I have to wait till, quote unquote, when I'm more advanced? I think those times are going to change because this trial already finished. This is the before chemotherapy, PSMA-4. And this study, and these are just some of the technical bits, do show an advantage of getting it, not unexpectedly, but what's really important here is that the FDA has not made the change yet. So we're gonna all have to wait, but I know that that's the burning question I get from my patients, which is, I've had an oral agent, I want this lutetium. So stay tuned, because I think those things will change. Now, is that the only sort of game in town? No, in drug development, we always have more in that same space. So another trial that was completed is known as the SPLASH trial. So this is a different company with their lutetium-177, and their top-line result was just reported out in December of last year, showing that they met their endpoint. So this is similar to the PSMA-4. It's a little bit like a race, but you know what? Competition is good. Competition is good. So if you can't get one drug from one place, you might be able to get another drug. So this is all percolating. So next year, if I'm standing up here again, that might be on the list more than just the one particular type. Remains, again, safe in terms of their results. Oh, but wait, there's more. We now have the ECLIPSE trial. So we have PSMA-4, we have SPLASH, and a third company has already also finished with their study, same 177 lutetium, different proprietary sort of product. Now there's 3. And then the bigger question is, come on, Dr. Heath, why are we waiting till I'm in the green box? Give it to me when I'm in the blue box, when we can get this even before we become castrate-resistant. And that study is ongoing, the PSMA addition. So it's happening. We're gonna know this data, and it's gonna be important. But I wanna show you this box because your doctor right now is probably relying on this particular slide on a daily basis. The top box is for folks with advanced resistant disease. These are NCCN guidelines of folks who've never had chemo, never had a hormone, a pill, nothing. And at the bottom, you have had chemo and you've had the pill. And why do I put this? 1, to show lutetium only shows up on that last box. Number 2, these are all of the different opportunities that your doc is thinking about when you do show up with advanced disease and thinking about the medication, the side effects, and whatnot. So if you know what's actually approved, and there are patient-level guidelines through NCCN, you also can then empower yourselves. Here's my last slide. My last check yesterday, there are 925 interventional and treating, accruing trials for men with prostate cancer. 925. There are a ton of other drugs in play. Consider enrolling whenever possible so we can move this field along. I'll stop there. Thank you so much, everyone.
What's the most important question I can ask you today? Do you know who Michigan's playing in football today?
I knew he was going to ask me that.
Do you know?
I don't. I'm sorry.
She has no life beyond her job.
I could have texted my husband, who's
This
a total
is what I'm
Michigan
telling you.
diehard.
This is like Mark Scholes. You know how dedicated they are. They have no hobbies. All they do is prostate. Thank God. Thank God for you. But I just wanted to test that theory. She's in Michigan. She's like down the street from me, and she doesn't know we're playing Texas.
Oh, right.
Oh my gosh. All right. I got about 5 minutes, then I got to make sure you go in the back. So let's go through a couple quick important things. Can you bring up my second slide? All right, now let me give you a heads up, and please don't roll your eyes.
Okay.
I believe the perception on clinical trials in general is you've given up, you're putting me in some kind of test, I might get a placebo. Why? I know you want me in a clinical trial, and you have it in your bio, clinical trial, but can you tell me why I should not be nervous about you suggesting a clinical trial as an option?
Because you guys are all contributing to the future, period. You look at PSMA addition, right? I just went over that. You want that lutetium-177 way up front. How are you going to get it? Are you going to fly to Germany and pay thousands of dollars on your private jet? If you do, take me. Forget him, take me, he'll be at the game. But I think a lot of it is, if I can't prove to you that what I'm going to poison you with is better than what exists, what am I doing? Now, you're right. Are you all guinea pigs on a trial? 100%. I lead with that in my own practice. I say that. Why is that important? Because it's a voluntary thing. You either feel like this is something you're going to pay it forward because you guys got a diagnosis that changed your life so you can help the next man, or it's not right for you. And guess what? Both answers are correct. This is not a mandatory, it's an opportunity. That's how I think about it.
But am I going to get a placebo?
Yeah.
Or are we going to get standard of care? Can you
Let me just
explain
say, in advanced cancer, anything, it's not even just prostate cancer, other cancers, no placebo. Because it is ethically not acceptable. If you have metastatic cancer, you don't get, some sort of sugar concoction because that's not standard of care. A trial, you will never get less than the standard of care. That's true in any setting, in any cancer, in any question. And if you feel like there is some boo-boo, that there is something less than standard of care, then you need to point it out and go, what's happening here? That's on you to tell us too.
Excellent. You know where I think oncologists go wrong? I think they go wrong when they use the word metastatic. Because can you explain so you said in all these slides, you said people aren't getting these tests when they're metastatic. But when I'm watching you give a talk or other oncologists, they'll describe metastatic as having cancer all over. Some will describe it as having just left the prostate. What do you mean by metastatic in that, which would then trigger that genetic test you're telling me about? So
Yeah.
I don't mean you oncologists, I mean the other ones. I mean like Mark
Thanks for that
Scholes
clarification. Yeah,
like that.
appreciate that. I mean, metastatic is defined by our staging criteria, which unfortunately is the most cumbersome, painful thing to look at. If you have a lymph node, you're considered metastatic. You're locally metastatic, but you're metastatic. So, is that a horrible thing to think about? Yes, because when you're a lymph node positive, on our guidelines, you're a stage 4. But are you the same stage 4 compared to the gentleman that has 20 liver metastases? Different biology. We just learned all of that today. They don't behave the same. So if you come in with liver metastases, yeah, you still should get genetic testing, but that's not the same person that has one lymph node recurrence because the PSA blipped up a bit from the prostatectomy he had 15 years ago. And you know that just based on that slide I showed you in terms of how long people live. Everybody's a 4 though. See, it doesn't make sense, right? So I don't get too hung up on that other than I tell you this is how we think and how we categorize things. But I think the question here, and you see that even in that free registry, you have prostate cancer, ask the question 99% of the time you're eligible for testing. And we didn't get into testing is a whole big other thing, which I think you have a session on as well during this meeting. But testing is complicated, and just also recognize your healthcare team may not know as well. It's a whole new world for everybody. So everybody's kind of learning together. But if you advocate for yourself and say, can we talk about genetic testing, inherited testing, germline testing, that's what I'm talking about.
Okay. So everyone here should be, I mean, the way you describe it, everyone here, the next time they meet with their doctor should say, do I qualify for genetic testing?
Right.
How many people have had that conversation with their doctor? About, what, 10%?
Yeah.
Okay, one thing you wish every patient knew here, this is a tough question to ask you, but one thing you wish every patient knew at this conference and also watching on the videos that are going to go out, one piece of stellar advice you wish everyone knew. Is that the genetic testing, or did I already mention it, or is there something different?
No, I mean, my thing is your voice matters. I think you get a diagnosis of cancer and all of a sudden you think everyone in the world is smarter than you. There's nobody who's an expert on you but you. So your voice matters. If you're getting some news that you don't understand, ask it again. Let me recap it. The docs like to talk. It's like 7 seconds on average. You go blah, blah, blah. Anyways, let me tell you how smart I am as professor. No, what you want is to be able to say, okay, you told me a bunch of things, Dr. Heath, let me say it back to you. When you say it back, it makes you recognize what you know and what you don't know, and everyone else in the room recognizes what you know and what you don't know. It doesn't matter what I say, it matters what you say. Okay? So your voice matters. Recap it, spit it back to your team. You'll be shocked at how that changes the conversation.
One thing you wish every doctor knew, or a doctor would know going into working with prostate cancer.
Honestly, they just need to stop talking.
Stop talking.
We talk a lot. I think we need to be better listeners.
Yeah.
You know, sometimes we come in with a set agenda. I read your records, I go, oh, so you've had this and you've had that. Got it, I'll be done in 10 minutes. That's not my job. Yes, my job is to know what are the options. My job is to listen to you. If you're showing up to talk to me, there's a reason you're coming to me. Either you're not understanding what other people have said, or you're just literally still in shock from the diagnosis, or you're there on behalf of a family member. We just need to get a better, we're always rushed, right? So we need to sit here and listen to you.
Can you repeat what you said during your talk about, I know I'm running over, I'm going to stop in the next minute or two, but you said 0.2. You said you want the PSA to be by 0.2 or lower at 7 months. Can you go back? I mean, I felt a lot of people writing in the room the moment you said that.
Yeah.
Can you elaborate a little bit? So that's my goal when I'm being treated, to go to 0.2 or lower?
Yeah. I mean, there are two sets of numbers. In the beginning when it was just the one shot, we knew that if you looked in 7 months and your number was less than 4, your cancer was going to behave somewhat well. It'll not be out of control. And what I mean about that is your PSA curve goes down and you go, yeah. If it doesn't hit below 4, chances are in the next few years it'll come right back quickly. That new data I showed was if you're on a shot and a pill, and this one was enzalutamide, those two things together in 7 months, if you hit 0.2, you will have the best prognosis survival in that patient group.
What if you hit 0.2 within a couple of weeks? Let's say you have is that better? If you hit 0.2 within a month, is that better than you hitting 0.2 in 6 months? So is faster better?
We don't know. because they only checked at one time point to make it comparable to just the injection that was from the last study.
What do you think? Do you think
Absolutely.
faster drop is better drop?
Yes.
Is a better prognostic
Yeah,
indicator?
I think the faster and the lowest that you get, your nadir,
Yeah.
is going to help us decide what's happening. And it doesn't matter if you start out at 5,000. You end up at the low number, thumbs up.
Wow.
I have folks that are 100 that can't get below that. It's 100, everyone's excited, they're at 10.
Wow.
But in a little while, that 10 will scooch up.
I can't let you leave here without you telling me what the next big drug is going to be approved. Which drug? This is not for a stock tip, by the way, for those people out. I like predictions. I like the fact that last time I talked to you, you thought a couple of the PARP inhibitors might get approved. So can you just tell me, and the reason I'm bringing this up is I saw, there's this thing called actinium that might compete with lutetium. It's a radioligand, right? And in Germany and other places, they're using it after someone fails Pluvicto.
Yeah.
I'm not saying it's past. So is that the next big drug that's going to happen in your field? Or, before I let you answer, here I am going through my notes, and they're interviewing this doctor about this new phase 3 trial, and the drug company is going to ask for approval. It's called Cabo and Tecentriq. It's Immunotherapy with another new drug, and they say they're phase 3. So what's the truth? What's the next drug that I should be excited about?
Maybe to save myself and not get in trouble, as I'm an investigator on way too many trials, I think the world of theranostics is what's next. Whether your isotope is lutetium, actinium, copper-64, it's a gamut. Just think back to your 9th grade chemistry table of stuff that we all cannot recite to this day, even if our life depended on it. All of those things are being used as cancer drugs because they have a way to deliver a way to kill the inside of the cell. That field of theranostics means I'm going to see it because I'm going to diagnose it through a PET scan, and then I'm going to treat it. That's going to be the next big area.
Nice. All right, you still can't go because what I did was, this year I did something different. I said, I don't call it AI or whatnot, I want to pull the top 3 questions that people submitted before you gave your talk. Can we go through these really quickly?
Go ahead.
If I can't handle hormone therapy, what do I do now? Because that's not a walk in the park. I mean, man's going into male menopause within a couple weeks.
Yeah.
And it's rough. So if I can't handle hormone therapy, what do I do?
Well, I think you just have to be realistic about what that means. You know, the way to control the cancer is to remove the testosterone. But if that end result is basically worse than death from cancer, honestly, then you don't do it. And you find a physician that can help you through this process, whether you're on these things or not, because you still need care. That's the bottom line. There are studies out there that are being used, that are looking at these newer drugs without being on hormone suppression. So in terms of what's going to happen in the next 5 years, they may materialize, and we may have a better answer from that. There are also studies that are giving back testosterone. So you're down, we give you back testosterone, kind of like bubble up the cancer, and then we hit it again with one of the pills. So all of this still is in works, but if you are not able to take this, don't stop going to the doctor. Because that's what happens a lot of times. We don't see you. That's not, however you are is however you are. Use your voice. If you can't do it, it doesn't mean we give up on the situation. We just treat it the best we can.
Yeah, look at all the different options for hormone therapy now,
Yep.
right? I mean, we classify it as the pills, the injections.
Yeah.
Okay, if I'm not handling Pluvicto well, this radioligand, what do I do next? If I'm having trouble with Pluvicto, whether it's dry mouth, dry throat, all the
Yeah.
things from clinical trials, is there something else? Do I take a break, or what do I do?
Just remember there's no cure with that medication, so it's helping you hopefully live better, live longer. But if it's not doing any of that, stop. There are other trials to consider. There are other trials with similar type drugs like actinium-225. So if it's really terrible, don't push forward.
last one that was popular is there's all this talk of getting chemo as early as possible when you would qualify. How do I know whether or not I qualify for getting chemotherapy early? Because chemotherapy still has the perception that it's used really late in the game, and now it's being used earlier and earlier. So how do I know if I'm one of those people that need it earlier and earlier?
If you are newly diagnosed and or have had cancer before, but now newly diagnosed with spread disease, and you're about to start your injection or your pill to take away your testosterone, you're a candidate for chemo as well as the pill or together. But the take-home message is you need more than just androgen deprivation, right? It's either a double or a triple. I have patients who feel that, you know, there's stuff in the liver, there's stuff in the lung. Give me the kitchen sink, give me the 3. And I have patients that have a few metastases in the bones. Forget the chemo, doc, I'll just take the pill. That's the conversation to have with your physician.
And if I'm one of those people that qualify for early chemotherapy, can you elaborate just for a moment, how long do I have to take chemotherapy for? I think some people think it's continuous.
Yeah, only 6 treatments. So
Can you repeat
it's
that again? How many?
only 6. So it's 1 medication dose every 3 weeks for 6 times. In 4 months, you're done.
Yep.
And then you continue on with the pills.
All right, so you've had such a great time here. We haven't coming here. I thought, what can I do? Those of you who weren't here last time she was here, we gave her an Oscar. I'm not kidding. And
It's in my office.
And her assistant said it was like one of the greatest, I don't know if she made this up, but she said it was one of the greatest gifts she'd ever received, and you put it up in the office.
It's in my office.
And I thought, oh my gosh, she's so enamored by it. What are we possibly going to give her now? And then I thought, you know, PCRI is doing really, really well. So I got inspired by watching Oprah. So can you show that Oprah clip that inspired me to do something for this audience to celebrate
Everybody
you?
in the audience, now listen to me carefully, is being given a special package, and I don't want you to open it. Do not open it. Cameras are on you, so do not open until I tell you. All right, open your boxes. Open your boxes. 1, 2, 3.
She's saying, you get a car, you get a car. So I've talked to Alex, and the budget's doing really well this year at PCRI, right? So I want to copy that. So in your honor, are you ready? They're handing it out. We're giving out free Heath bars. You get a bar. You get a bar. You get a Heath bar. You get a Heath bar. You get a Heath bar.
Oh my gosh.
Give Dr. Heath a Heath bar. She should have a Heath bar.
Oh my gosh.
Heath bar for you. You get a Heath bar. That's better than a car. Better than a car, right?
I thought he was going to give us all a car. That's
Someone's
hysterical.
got to give Dr. Heath bar. Any chance that you are heir to that fortune? The Heath company?
Yeah, no, sorry. Sorry.
All right, everybody getting their Heath bar? It's toffee. It's delicious. Sorry for those of you who thought you were going to get a car. There you go. You get a Heath bar. All
Woo!
right. And you're not done yet.
Oh.
We gave you one
There's more.
gift. All right? Now, because I've been doing this 35 years, I know I look 20, 25, but the reality is I get the inside track. I've been friends with all the oncologists and the urologists. I got to play Switzerland. So I'm going to make an announcement here. Don't get mad at me. I'm going to make an announcement that nobody knows, and I told her I'm just going to make it. And it's not just also about celebrating you. Sometimes we just have to celebrate family. In the next few weeks, Dr. Heath is leaving Michigan. And that's sad for me. But when I understand what she's doing, it's going to change countless lives just in terms of the position and the authority in her voice. She is going to run oncology at the Mayo Clinic in Rochester.
Thank you.
I almost got Barbara Walters there. I was like verklempt. It's sad because she's been there. We've been good friends. But I'm so happy that you're going to be at the Mayo Clinic, running the Mayo Clinic. Detroit, Michigan is really going to miss you. I'm not going to miss your football knowledge. You don't have any.
I don't have any.
But the reality is that I think when they announce it, this is like one of the happiest moments I could be for another doctor. There's no one better deserving to run the Mayo program than this person right here. So we decided to give her a cup that says, "Cancer's worst nightmare, Elisabeth Heath, MD." So thank you so much for doing this. She's going to go in the back and answer questions.
Thank you, you guys. Thank you so much.